So a little bit on nothing present here. So I wish I could add a ton of new things, but when you're a peasant speaking amongst gods here, I'm going to go with tried and true, but really speak to the different opportunities to try to address pathology. And so the big key is understanding the pathology. And to one of my mentors, obviously, Bill Hamilton has mentored a number of us and been a great colleague to a number of us. And this study from 1982, foot and ankle, really still speaks to this day. And just understanding the pathology, a number of the great talks have already alluded to this, of understanding the pathology of the FHL. In my practice, the only aberrant pathology that I have occasionally seen in recent is this aberrant FDL that can sometimes cause congestion and symptomology there. But this is really the pathology we must understand and the impact it has on stenosing the FHL longus tendon and driving posterior impingement, particularly in dancers. For me, this is also a great study, a great review from Giannini's group looking at the posterior ankle impingement, much of which has been discussed here already, but understanding that variability and variation of posterior ankle pathology and also the different cystic formations that can exist in the posterior subtalar joint that also may impact the FHL. When we really look at this and understand that stenosis that occurs laterally, but also can provide symptomology medially, that is really, it's really what is actually giving the FHL problems versus the FHL itself. And the FHL is doing what any tendon would do and muscle if being strangulated by bony or cartilaginous pathology. And so this is a great image really looking at the posterior arthroscopy approach, advanced imaging here showing a large os and probably an acute fracture. I'm not as brave as I have to say many of my senior colleagues and showing the videos and not collapsing, considering my video wasn't even working earlier. But if we look at the spectrum of this essentially array of when I do approach these arthroscopically, I go directly posterior, as stated by Dr. Stone, and essentially that continuum of seeing the cloud of scar tissue, posterior ankle fat pad, and then working your way across to essentially identifying the FHL. I mentioned to Dr. Garcia in the thread, since I heard one of his talks 3 years ago, my go-to in dancers is now converted to open in majority of cases with a posterior medial approach and recovery similar to his approach. And I find it to be very successful. Again, the open posterior approach is tried and true. I believe it reliable and allows me to address all the pathology that may be hiding from me or that may be elusive through other approaches. In this particular case, a 16-year-old ballet dancer, pre-professional school, pain on endpoint. We identify this here. Again, removed and has returned quite well. In conclusion, open posterior medial is my workhorse. Understand the pathology. The FHL is just angry with all the things that are essentially impinging upon it, and know what you're dealing with.